We are now live streaming, hopefully, on Facebook. Hopefully you can all hear us. If you can hear us and you can see us, can you please give us a like or a comment so that we know that there's some people out there actually listening to us. My name is Amanda and I am one of the DSN Forum team. Today we have with us some special guests, but firstly I will just let the rest of the team introduce themselves. So Beth.
Hi, I'm Beth. So I'm a DSN down in Southampton, but I'm also part of the DSN Forum team with the girls.
Tamsin.
Hi, I'm Tamsin Vetchesall and I'm a DSN for the Royal State University Hospital in Stoke-on-Trent.
And Vicky.
Hi, I'm Vicky Alabrava. I'm a community diabetes specialist nurse in Liverpool.
And that's our team. And our special guest today, we have Gerry Rayman.
Hello, Gerry.
Do you want to tell us who you are, Gerry, for our listeners out there?
I'm a consultant diabetologist at Ipswich Hospital. I've also been co-lead for GIRFT together with Partha, and I also chair the National Diabetes Inpatient Network.
Brilliant. And then the person that needs no introduction at all, we have Partha.
Hi, Partha, consultant diabetes in Portsmouth, GIRFT co-lead, and NHS England National Specialty Advisor. So,
thank you. So today we are going to talk all about the Get It Right First Time audit that went on this year. So I'm going to hand over to Gerry, who can tell us all about what happened. You know, how many hospitals did you see? What were you looking for? All of that kind of stuff. And just give us a brief sort of overview of what you did.
Okay, so first of all, the GIRFT, what is GIRFT? GIRFT is going to try and improve care, not only for diabetes, but other specialty areas across the country. And it was started by an orthopedic surgeon, Tim Briggs, who noticed that within his own trust, there was massive variation in practice and quite costly joint replacements used by some and less expensive by others and so on, and different practices in terms of some places bringing people in, some surgeons bringing people in for day case surgery, whereas others were bringing them in for electives, the same procedure, electively spending a lot longer in hospital. And within the group, they decided to try and streamline care, best practice, and they saved a lot of money. And now that's gone out to lots of other specialties. And diabetes is the first of the medical specialties. So this involved Partha and myself visiting 108 hospitals across the country to look at their practices, to understand the difficulties that they were facing in terms of funding, staffing requirements, and so on. There was massive variation here. Some places were really well established in terms of their diabetes services and producing fantastic outcomes, very close working with their management teams, great deal of support, and other trusts where there really was very little support for the diabetes team. I should say, one of the really important things that we learned was that virtually every diabetes team we went to visit were really keen on delivering the best diabetes care they could. And I think that says so much of our colleagues and so much of the people who work in diabetes, but many were just feeling so frustrated that they didn't have the support that they need. And that's what GIRFT is about, is actually to try and make sure that we can deliver better care, particularly in those places which are struggling. So I'm going to kind of leave it like that, but except to say that you probably all know that there were three main areas that we looked at. One was inpatient diabetes, the second was type 1 diabetes, and the third is diabetic foot disease, because we felt that those were the three areas where we could make the greatest deal of difference. And they are relatively neglected, and particularly inpatient diabetes. As you all know, I've been working on inpatient diabetes for over 10 years. GIRFT is going to make a really big difference to that, and particularly the funding which NHS England is now putting into those three areas of care where we identified need for change. I'm going to hand back to you, Amanda, to bring in Partha.
Yeah, and so Partha, what kind of changes are we going to see then with the funding from NHS England?
So I think I'm going to start off by just saying thank you to you all for hosting us. I think the DSN Forum, as me and Gerry have spoken about, I think you guys are doing a great work around the country, raising the profile, etc. And it fits in very nicely with the question you've just raised. What are the changes you're going to see? Well, I think if you take a step back, one of the fundamentals we want to do is make sure that there isn't any more hospital around which doesn't have an inpatient diabetes team. I think that's the starting point. You know, the Nadia report has shown that there are certain trusts which still don't have any. And I don't think that should be an acceptable position at all anymore with all the data we have got. Normally people then say that, oh, well, you know, we don't have the money to do it. And the first answer is yes, there is money specifically for that. The next thing you hear is that, oh, we don't necessarily have the staff. And I think this is where wider roles come into play. If we don't have specialist nurse colleagues out there who are available to do the inpatient safety work, as Gerry and I have said in the report, and as we have seen, this is where pharmacist colleagues come in. So I think there is a huge opportunity here to use the funding and basically, you know, just learn from the good examples. You don't have to be, and that was one of the things I would say, is that you don't have to be a super big trust with, you know, all bells and whistles to be a fantastic inpatient diabetes providing services. We've gone into really small trusts, not on the radar or map, so to speak. And they have got some amazing, amazing ways of delivering inpatient diabetes services. And I think that's been one of the learnings for us. You know, we have come across hospitals which we didn't know had such amazing services. So I think hopefully GIRFT will do that. And as you know, we're quite keen to make sure those recommendations we have are done. That this report doesn't just sit on a shelf.
The other thing, Partha, which we came across some really big trusts, fantastically well staffed, and yet they were delivering pretty poor inpatient diabetes care. They were just reactive. So they had no idea who had diabetes in the hospital until a problem arose. And that, you know, that's got to be corrected. The service needs to be proactive. You need to know who's likely to get into difficulty within your trust and be looking out for to see whether problems can be prevented.
So the places that did have that, what kind of systems did they have where you could see who the people with diabetes is? Because I know that in some hospitals, there's no system to identify these patients, but what did the systems look like who could identify the patients?
It can be quite difficult. Those with electronic records tend to be able to do that better because they've got a history of previous admissions and so on. Some people have been using the retinal screening registers, which have got NHS numbers, and when the patients come in, they run the numbers, the patient's number against the retinal screening record, and that will identify patients. There's some governance issues over that, which have prevented all trusts doing it, but a number of trusts have been able to get over the governance issues. Others have been, for example, in our trust, triangulate data. So we've got a history of previous admissions which are flagged. We've got a history of anyone who attends the diabetes centre, and we also have access to System 1 GP databases. So by triangulating the information, we can probably identify 95% of those who come in. But it is difficult, and those are IT problems which need to be solved, and that is something that we're going to be looking at going forward. So we have said everyone should be identified, everyone with diabetes on admission, but we need to sort out how exactly we can best do that.
So Gerry, what were the top of all the three things that you looked at? What were the top sort of findings in each category? I know it's probably a lot to go through the whole report, but the sort of top things that were recommended or?
Well, I think if you take inpatients, absolutely staffing is the key. And in fact, that's the bottom line of a lot of diabetes services. It's not so much equipment. I think we can talk about equipment for the type 1, which is definitely the future, but it's not so much about equipment like cardiology or other services, we are about people, aren't we? We are about supporting people with diabetes. So staffing is the top thing in the inpatient work. Staffing again for the multidisciplinary foot team. And then for the type 1, staffing again is key. And the other important bit is getting staff up to speed with the new technologies. And I think we're all lagging way behind on that. In fact, many of the patients are beyond the staff. And we all know that, don't we? Partha, what are your thoughts?
Yeah, I mean, I think, Gerry has mentioned about the inpatient. I think number one thing, one top thing to pick up from the inpatient, as Gerry mentioned, is about the close the gap as far as the staffing goes. I think that's the main thing. You think wider beyond. I think for type 1 diabetes, my main takeaway would be the education of the staff and how rigid we are in our thinking sometimes in type 1 diabetes, whether it's not got the necessary focus or whatever over the years, whether we have always talked about, we've talked about, oh, let's make diabetes a community service and a community wider out in the community. And that's been the right approach for type 2 diabetes, and whether type 1 diabetes has got lost in that. But I think the other Achilles heel was clearly the peds to adults bit. That is a major issue across the country in adult teams. And a lot of it was, so if you look at good examples, when we talk about Liverpool and Poole and all those places, you've got Reza and Fulia working there. And in Poole, you've got Mike Masding and Joe Dalton and their colleagues. It is not that they had extra funding to do it, right? The principle was that they just had really good relationship with the pediatric teams and knew what they wanted to do to use the pre-existing system to make it happen. So I think there is a bit of learning from others as to how to have smooth transition. And I think, if you see the data, the biggest spike we have during that DK admission, we all know it, right? We see those patients from time and time again. And a lot of it is because they fall out of the pediatric services. So I think that would be the main thing. And finally, for the foot, I would say having a multidisciplinary foot team. Simple things like, do you actually meet each other to discuss about your foot patients? That to me sounds like something everybody should do. And then you went to trust where they were like, not really, we don't. And you go like, well, that's just good practice, so how can you not meet with your vascular colleagues or your podiatry colleagues to discuss your patients and learn from it? So some of them are very, we've tried to distill it down by saying, look at what has come from the, the Southwest, the 10 recommendations, and just have that in your foot service. And none of them are impossible things, so to speak. And I think that would be my feedback. So I think to all the audience who listen on, and I think if there are people with diabetes listening, my top tip would be look at the data and make sure your local team is doing that, right? And none of those are linked with, oh, we need tons and tons of money to sort this. And it goes back to the first point we were saying, and if it is money, then the question has to be, well, why haven't you liaised with your local network to get access to the transformation funds? That's exactly why we have put the funds out with a very clear 2-point remit, which is improve safety in hospitals, improve amputation rates. And of course, there is education treatment targets, but that's the way I would look at it. So it's not, I think it's a very glib word that we keep on saying, but clinical leadership is an issue across the country. You can, and all of you know, you can close your eyes and name the top 10 diabetes centers in the country, right? And you can also close your eyes and say, I know why that's down to. There will be one individual, one person or a couple of people have got together. So I think that's what probably needs to be stronger, I would say.
If I can just, the other thing which is really interesting is the delivery of type 1 diabetes services by specialists. And we went to some areas where, according to the size of their population, they should have 2,000 people with type 1 diabetes on their books. And they had 300. So the question was, where are the other 1,700? And the answer was, well, they're somewhere in primary care. Mm-hmm. And so we then asked the CCG leads in diabetes, so tell us about the services you're providing to the type 1s in the primary care. And there was nothing. They were just turning up for their insulin. Now that's just nonsense. And that, that's got to stop. the London network is looking forward to standing their services up again after COVID, and they recognize that this is something that they really need to invest into, is finding out all the type 1s in the community and making sure that proper type 1 diabetes services are delivered to those people. I think we've really slipped a lot in type 1 diabetes.
So thank you, Gerry. That's really, really insightful. We have a few questions coming through on the chat and on Facebook. So, and I would encourage anyone that is watching, please do put all of your questions. If you're live on Zoom with us, then put them in the chat box. If you're on Facebook, then please put them in the comments. I'm going to go to Beth, who's going to ask the first question.
Thank you. So one from May, who we know loves to ask a question, guys. You mentioned poor staffing. What is the recommended staffing ratios, e.g. for like inpatient DSNs for a population, for example, covering 350,000? What would you say the DSN ratio needs to be for something like that?
So if I can answer this part, because you may not know this.
You're the king of inpatients. Please carry on, Gerry.
There's some work done by ABCD and the DISN group. They have a formula. It's not in my head at the moment, okay, but it's really useful. So within our area in the east of England, our network lead, Liz Bennett, has had us apply the formula for each hospital in the region, and the NHS funding, the transformation funding, she has made that funding available to make sure that we have the correct number of DISNs in each trust. And I think that's really what we've got to push for in the other areas, the other regions. It's apparently up to the region to decide on what they're going to prioritize to spend the money on, but I think we really need to push around the inpatient staffing levels and using the formula that we've used in the east of England. And then the fact is the money is there, and if you don't step up to the mark and apply for the money, I'm afraid you're letting your service down.
Yeah, so I would just add one more thing to it, is that if you look at the way the calculation was done, so we have to obviously go and make the case to the Department of Health and everybody for funding to be allowed from taxpayers' money to say that this is where the funding would be. It is always prevaricated on certain numbers, that this number of staffing will help prevent that number of errors and thereby save us money, right? So it's worthwhile looking at that piece of work, which was done. Is it Marion Kerr did the work, didn't she? Yes, I think.
Yeah.
Gerry? So it's worthwhile looking at that piece of work because that was the fundamental base on which those calculations were done for the request of money. So going back to Gerry's point, I think what we need to do, this is what my advice to every system for inpatient would be, is look at your Nadia data. It's now out. Look at your staffing. Look at the funding and see if you've got enough ammunition there to make the case to your local system. This is why we need that staffing to close that gap, right? And one final bit is that it's not just about errors, even though it's the most safe thing. One of the big things that we found resonated really strongly with chief execs and medical directors when the length of stay. So some hospitals, the length of stay for people with diabetes were 10 days more than somebody without diabetes. Well, the national average is about 2. So I think the question then becomes, well, why didn't you just get to the national average? You would have saved 8 days there, right? So I think things like that make a big difference. So my advice is, your trust has a GIRFT report, your Nadia report is out, work them two together. You have a very strong case then to take it to your local network for the funding. That's the way to approach it.
Wow. Okay, well, I think we have another question now from Vicky.
Oh, yeah, so there was a question just in Facebook here from Leon. So there is a postcode lottery with aspects to different areas and funding for their type 1 diabetes services. And this can be hard to navigate for secondary care who cover multiple counties. Have we got any advice from that? Obviously, it comes back down to funding, doesn't it, again?
So I think the thing I would say, there is no specific funding for type 1 diabetes care. There never has been. Diabetes care in funding is not divided into type 1 and type 2 and gestational. You know, that's not how it works. There is diabetes funding, okay? So the person who said that, absolutely right. It's different across CCGs, which is exactly why the system is moving towards STPs. So it's much more wider rather than being fixed into funding for that. So that's the evolving of the NHS, which is why the funding that's been distributed for the transformation funds have been given to the systems rather than just to CCGs. So you can stop having those debates about, okay, it's one CC, what about the patient who comes from across the border and what do we do now? So that's why it's being moved to systems with it evolving down, saying that, no, you need to work across as a patch and make that happen. So that's the way we are trying to address that.
Okay, next question I think Tamsin has for Gerry.
So those hospitals that obviously due to COVID didn't get their actual face-to-face GIRFT visit, will they be getting one in the future, or a bit of a follow-on, or is the fact that obviously Nadia is changing and evolving over the next sort of 12 to 24 months, is that sort of taking over instead of the GIRFT visit?
So we're really disappointed that we had to not visit. I think there were about 26 trusts left to visit. There is a plan to make those virtual visits. Now, Partha and my time is actually not as available as previous. And so we're having discussions about how we do that, but we would like to complete it, even if it just involves sending out the report to those trusts that haven't been visited.
So Gerry's being very polite as well. So I'll tell you one other thing, which I'm very happy to put on record.
Gerry's always polite.
Yeah. So let's be very honest. Lots of trusts didn't take up our offer for visit when they had the time. Those 26 trusts were asked at least 3 or 4 times, if not more, by our teams. And they said they were busy, they had other priority, they didn't do it. So, and then COVID came along and we couldn't do it anymore, right? So I think my view would be, if in the future we get back to a position of doing this, then please take up the opportunity. That's what me and Gerry were doing, right? So we, as I said, you know, out of 134, we did 108 or 110 or whatever it was. And there was only a handful left. And the handful we kept on asking and we never got any response. And obviously we'll mention later on about Yvonne, who was fantastic in our team as one of her managers. I mean, God knows how many times she kept on asking and got no answer back. So I think there's a bit of swings and roundabouts about it as well as those trusts. So we are where we are. Hindsight is 20/20, as they say.
It's difficult. You can't even make it mandatory either, because you need all of the people there at the right time, isn't it? So it's not like you can just say, right, we're turning up. Yeah, it's very difficult. So Beth, I think you have a question.
Yeah, so it's something that came up in the forum the other day actually, was what are the plans for kind of like spoke hospitals or specialist hospitals that are maybe not, like one of the examples was like a specialist oncology hospital that obviously have patients there with inpatients with diabetes and things, but weren't necessarily seen under the GIRFT. So how do they go about navigating the kind of recommendations? Because they do have some DSNs that work in that hospital.
So I'll give you my view, and then I think Gerry, obviously the inpatient side, will have to give his views. I think some of the principles which are in the GIRFT report applies to any hospital. If you ask, it's got nothing to do with an acute. I mean, the fact about identifying your patient, the fact that you have staffing to look after them, safety, wherever you are, insulin errors wherever you are. So I don't think, yes, we do not measure them, quite as you say, but do these apply only to acutes, and do they not apply to, for example, a mental health care hospital whereby you might have a lot of people with diabetes? No, it applies exactly the same principle. So it is a great question, and something that me and Gerry are quite keen to pick up later on and see what we can do to sort of, I think for me, the principles are the same, whichever hospital you're in. That's the way I would look at it.
And Beth, one of my concerns going forward is that there are now going to be surgical hospitals set up specifically doing, you know, concentrating on particular procedures like hips, knees, and so on. And they will be outside of the District General Hospital. And there, at the moment, there's no clear indication that they're going to interact with the diabetes inpatient services or have a satellite diabetes service or some. So we need to think about what's going to happen there if these things are going to develop, and it sounds like they're going to develop. And we have been in discussion through GIRFT around this, but again, it means splitting your team to a certain extent, so or working virtually, but clearly we're going to need to have something to make sure that people going for elective surgery with diabetes have the support that they would otherwise have got in a well-functioning district general hospital or teaching hospital.
We've got a question from May. Partha, who holds all controlling power to distribute the funds in the system?
You do. You do. I think you do as clinicians. I think, let me give you my example of where we are, okay? So I'm aware of the funds that come to our system, right? Hampshire, Isle of Wight. And as the local clinician, I've straight away sent an email to the CCG lead saying, I'm aware transformation funds have arrived. What's the process? Okay. I have let Phil Newland-Jones know from Southampton because he's my colleague. I've let the Hampshire guys know, and I've let our community providers know. And I've said, guys, here's an opportunity. We need to get around the table. And if the money is coming to this system, well, let's get them around the table and talk about it. That's exactly what we're doing on the 26th of November. Right? We're all getting around. We're going to have a, online just like this, and all systems are going to put forward what they think are their priority. We're going to look at the data which is available. And does that mean that, for example, Portsmouth will get everything they want? No. And I appreciate that, because some other trusts, for example, if you look at us, do we have enough inpatient diabetes nurses? Yeah, pretty well, probably not as much as we like, but it's certainly better than some other hospitals in the region. So should they get priority? Well, the answer is 100% they should. Because if we got 2 and they got 0, well, surely we need to tackle the 0, right? So I would suggest to everybody in the system, you really need to think a bit wider, because getting a hospital from 3 DSNs to 3.5, and then if your colleague has got 0, you have to go and support your colleague. So I think that's the approach we need as a system. So, and whether, for example, I'll give you one example, type 1 diabetes, what would we love to do? I would love to have a psychology session, but split across Southampton and a bit in Portsmouth and a bit in Hampshire and the acutes for the type 1. That would be amazing, you're right. But you don't have to go and ask that just as PHT or just as my hospital. So I think that's the approach I would favor. So to May's question, my strong suggestion would be, if you're not getting anywhere with your system, involve us, we will ping you to the right people. And if you're still not getting traction, well, we can ask the question, where is the funds going? So that's what I would say. So nobody's got the power, if that makes sense. But you can definitely make influence and make it happen.
Just to give you an example, we had a meeting last night, or yesterday afternoon, early evening, with our STP, all the clinical leads within our STP around the transformation funding. And we are working together to decide what the priorities should be for each of the different parts of the STP. And so a hospital down the road from us who's got a much smaller inpatient service, and we want the money to go to them.
Yeah.
It's got to be leveling up.
Yep.
We know that there are deficiencies in the multidisciplinary team, particularly historically, there are differences across the various communities within CCGs within the STP, and again, we're looking to level those up. And so we are agreeing amongst ourselves how we should spend the money, and we being clinicians, not the commissioners.
Okay. Is there anything being done with procurement nationally, to kind of reduce variation?
So yes, is the short answer. In the report, we have clearly specified, and I've already, well, not just hinted towards it, we have been very clear. There are three major things which we're looking at. One is technology. And I think the answer is that wherever you are in the country, you should have access to all the technology that's available, all the pumps, all the CGM, etc. Not just go to region A and they said, oh, we don't do pump X. And then region B goes like, it doesn't matter if you want pump Y because we only do pump X. That needs to stop. So that piece of work is going on to level the variation. The second piece of work is glucose strips, and we want to pick it up and look at the huge variation in prescribing around it and the sort of whole quality issue index around it. And thirdly, it is about, can we look at all the prescribing within type 2 diabetes and say, well, actually, some of the money that we are spending is in excess. So should we then move it to, for example, better drugs in type 2 diabetes, which have come out based on the evidence base, right? DPP-4 inhibitors, SGLT2 inhibitors, GLP-1 analogs, all of that. Those discussions need to happen, especially when you've got drugs coming out with, end organ outcomes, so to speak. So those conversations are ongoing. And as we have clearly said in the procurement piece, that's how we intend to shift some of the money around. So it's a big piece of work, not done before, and it's going to ruffle a few feathers and a bit. But I think if that releases money for systems to get extra staffing, it is what it is. So yeah.
I'm going to leave that one to Partha, really. That's going to be a pretty big battle, that one.
Definitely. We've got loads of questions coming through on all the different social media sites that we're on. So Tamsin, do you want to read some of the questions out?
Yeah, so Sanjay said, I think probably a little bit from my question actually, will these hospitals will have a repeat visit basically for GIRFT? Is this something moving forward that this will happen as well as the hospitals doing the NADIA audit, or was this just a one-off visit with a recommendation plan?
So GIRFT has had a number of changes, and we did have implementation managers who should go in and find out what the trust has done following the visit. Those managers are now a little bit thin on the ground, so that's not happening to the same extent. But I think what's going to happen is that the networks will pick up quite a lot of this to find out what is happening within the trust. So the visits are going to be via network leads and via network meetings, so to speak. So benchmarking will be done within regions through the network.
I think Beth's got another question.
Just some more questions about, there's quite a lot of questions about how people can actually access the transformation money and things. One of them specifically was how they can access developing a business case for incorporating psychology support, which I know quite everyone's really wanting to get. And I know that Rose Stewart has offered some support with things like that, haven't they, Partha? So you might just want to...
For sure. My advice always has been with the psychology thing is that I think people are getting too wrapped up in the whole thing of show me the evidence that a psychologist reduces your HbA1c. And I think that's the silliest argument I've ever heard on the planet, because I'm not aware of any study whereby you're showing that, a DSN or a consultant reduces people's HbA1c by 1 or 2%. I'm not aware of anybody doing randomized controlled trials to find that out. How do you do that? I mean, it's not even ethical. So I think if you want to progress, you need to follow NICE guidelines and say a psychology time is part of my team, right? And you move with it. You have to look at evidence base that's out there, teams which have achieved better. Rose obviously has given some examples. You've got other areas around the country where they've achieved with psychology. That's what you need to do. I genuinely don't think this argument will ever go away if you keep on saying, show me the evidence that psychology can improve HbA1c. Unless and until you look at diabetes as a physical and mental health paradigm together, it's a silly debate forever and ever and ever. That's what I would say.
I think the sad thing about psychology is that they're not enough.
Yeah.
We're not training enough across the country. And forget diabetes, just mental health is really a big issue for our population today. I don't know how we solve that, but that doesn't mean that we shouldn't make every effort to make sure that we can get some funding so that if there are people who are interested, that we can support them.
Yeah, I mean, you guys made it a recommendation in the report, didn't you, for young adults to have psychology service?
Yeah, I mean, I think, young adults obviously is a big area simply because of the, you can see the spike of HbA1c, you can see the spike of, admissions, etc. But I also think that, to Gerry's point, as he said, the staffing is an issue. So how much are the other staff doing to learn about psychology, pick up the pieces? I don't think you need a psychologist for everything. I think it's also about, ties into the language matters and all the sort of work you do. Sometimes it's about those little interactions we have with people and, the impacts that we leave and all that. So I think there's a lot of training as well for other staff to learn about mental health side of things. So that's what I think.
So for the transitional bit and the young adults, I think there are psychologists with the pediatric services. And sometimes they're only a bit part-time. So if we can use some of the funding to make them more full-time or extend their hours so they can reach into the
Adult side, yeah.
older youngsters, so to speak.
So I'm not sure if we've got any more questions. Vicky, is there any more on Facebook?
Not that I can see, but I wanted to ask about with the young people in the transition, obviously for those going away to university, and some may choose to continue with their diabetes team, obviously where they live, and not register with a GP or be seen where they're actually away at university. Do you think that has some influence on sort of the DKA rates, and obviously because they haven't got a point of contact in their new local environment?
I personally think yes, because I think there's a drop off of clinical contact or somebody they can go to for their type 1 diabetes. So one of the pieces of work that I do want to pick up next year is looking at that unit, because there's some good advice around university, what to do when you go to university, but it doesn't quite have the other bit of how does it work across the board if you're saying you transfer across, right? Let's say you go from Portsmouth to Liverpool, right? How do I ensure that one of my patients, how can I flag to one of my colleagues in Liverpool to say, this person has gone from the, so I think that seamless link isn't there in the sense of, let's say they were under pediatrics in Portsmouth, then became an adult, and then they went to Liverpool. So how do I let you guys know that actually one of my patients has gone there? Would you mind picking up for any urgent issues? Well, I'll continue to provide the other care when they come back for their holidays and stuff and breaks. So that's a process which I'm quite keen to look into. So certainly next year, that's something I'll probably be picking up across the board with universities.
Yeah,
I think it is an issue, but I think it can be managed. So we have sessions prior to going to university with the youngsters, what to expect and all that sort of business. But also, I think there's quite a lot of personal care. So they can contact us whenever they have difficulties, and that often does happen. We do encourage them, obviously, to register with the clinic, with university clinics and so on. But I think it's a very open access, I think, is the key thing there.
Yeah.
So we've got May waiting in the wings, and she's going to come on live now and ask you a question herself, because she's dying to speak to you both.
Thanks. I'm not dying to but thank you so much, Partha and Gerry, for such an interesting topic. As the pediatrician in the group, I obviously see the other side of how much difference there is in staffing with the lack of BPT in our adult diabetes colleagues. So my question, hopefully the final one from me today, is that whilst the NHS have limited funds, Gerry, and there's so much work being put into GIRFT and the lovely report that you did, how is funding prioritized? And for example, is a unit where there is one DSN compared to a similar unit with 4 DSNs, is DSN prioritization of staffing more compared to a service where it doesn't have foot care in their diabetes service, or no transition? And someone mentioned psychology. Who decides this? Is it the stronger voice, or the trust which has got all the fancy business cases wins? I hope not, but that is my concern.
So there are 4 priorities, right? As far as the transformation funds go, okay, which is inpatient safety, amputation rates reduction, treatment and care, treatment targets, and education, okay? As regards those 4, the top two prioritized because of the impact on the financial side of things is inpatient and amputations as things stand. So going back to your question, what happened? Does it become like a battleground as to who gets the money?
Yep.
The answer is probably mixed. I think in some areas, yes, you're absolutely right. I think there is a lot to learn, I would say, from the approach taken by the London network in that respect. Because even though they have big gun hospitals around, their distribution and the work done by Steve Thomas in that area has been quite exemplary, whereby he's not just gone like, do you know what, I work in guys, all we'll do is we'll get more and more resource for guys. He hasn't done that. He has been a really good leader across the system, looked at the data. And I go back to May is that, so what we have done this time, we have stayed away from trying to central pressure this, okay? Because frankly, it's not possible. We've tried that, and those of you know, and trying to do something centrally like we've done with Libra, it's just soul sapping, if that makes sense. So you have to depend a lot on local leadership to deliver it. So for example, we meet, Gerry and us, we sort of meet once every 2 weeks or so, which is called the local networks, isn't it, Gerry? So you've got local clinical leaders from across the system. I would strongly say that they are the ones who they are, for want of a better word, are representatives in the local system. So look at the network and make those calls. And I would say those will be the people who should be leading the change and saying, do you know what, guys, I know you might be disappointed as a big hospital that you're not going from 3 nurses to 4, but that hospital has got no transition. And the data suggests that actually care is poor. So I think it's not just about saying who's got more or less. You have to have the data to back it, okay? So if, for example, a local area shows it's because we have no transition service, and look at what's happening to our HbA1c levels in the NDA, in the adult NDA, and our admission rates, you've got a far more stronger case than somebody who's saying 3 to 4, if that makes sense. So I think there'll be a bit of mixture of things going along, but yes, it does devolve a lot down to who will be the leaders. And I think, you know, Gerry and I both said in our local system, we could easily be quite strong voice and divert a lot of fund towards our own hospitals, right?
Yep.
But that would be silly given that we're trying to work as a diabetes community. And as you said, we've only got finite funds. So some of it will be, some of it won't. So I would strongly push, you know, you're the local pediatrician, you have got responsibility of your young adults. There is no reason you should not be involved in the pack and making that voice quite clear. And if you're not happy,
that's why I'm here. I think it really is very dependent on the system and local leadership. And I did say to Gerry, not everyone would be as noble as you, and there will be some temptation of even clinical leaderships trying to obtain more of the funds, isn't it? To improve, we can improve in every aspect, but there is a limit to what the funds are.
Yeah, no, absolutely.
One of my thoughts about this is, again, and it's happened with us, the more people you get together, the more those loud voices are diluted when you're coming to make a common sense collective decision. What is fair and what is not fair becomes fairly obvious. So I would suggest that working through a wider group of clinicians, I think that will really help. And that's what Steve Thomas has done in London. He's got them all together, and it's quite clear who's shouting the most and who has got needs, and collectively, I think you find that the right decisions are made.
Very interesting. All right, I think we're coming to the end of the questions now. So unless there's any more come up on Facebook, Beth, Vicky, no? Okay, so I think that's the end of the questions. So I'm just going to say thank you so much for coming today. It's been really great. Using your Saturday morning, you've given up your Saturday morning off to come and talk to us. So thank you so much, guys. Can we just have a closing statement, a closing message out to people about their reports? Gerry?
Well, first of all, it was a real pleasure doing this. So thank you very much for the invitation. And actually, it's lovely to see all your smiling faces this morning. Look, this is a real opportunity for us. The GIRFT report really does address some absolutely essential areas in diabetes care. And if we can get this report acted upon, and that there's quite a lot of work to do that, but if we can get it acted upon, it will make a massive difference. And I can tell you, if we get the inpatient nurses that we require, and that's up to you guys, right, to push for getting that funding, if you get those inpatient nurses in place, I can tell you, you will definitely improve inpatient care and reduce the cost. The benefits are massive. For the type 1 patients, as I said before, we really are, I think that has been a Cinderella area, and Partha is doing a fantastic job in promoting type 1 diabetes. So we all need to get behind this. And of course, you all know where I started. I started in the diabetic foot, right? And so quite a lot of the things that we've seen recommended in that document, actually I did 17 years ago, and we reduced our amputation rates by 75%. It's taken a long time to actually get this to be widespread across the country. Now, we've got, Partha talked about the Southwest, the 10 principal structures of care that they put in, and they changed their amputation rates by 50% within 2 years, right? We got to do that across the country.
Amazing. And Partha, your closing words?
Yeah, I just wanted to say just a quick thank you to a few people because of in the journey. So, you know, a team called Methods who helped us with the data, and we had Yvonne Frewin, and we can't do any talk without Yvonne Frewin because she honestly she's been amazing, as Gerry will tell you, over all the journeys, being our partner, being all to these writing of the reports, Hassan who developed the report, and other colleagues like James Murphy. So that's just to say that thank you to them. Well, my finishing bits would be is that I think diabetes community and anybody who has diabetes should be really encouraged by a lot of the good things we have seen. All I can say is that there is a absolute plethora of really good, keen people. And if you have diabetes, all I can say is that it appears to be in really good hands. We are not here looking at a system which is failing by any means. What we're looking at is certain areas which need a bit of help to get up to the other areas. And I think that's really encouraging to see. So I think follow the 3 guidelines is what I would say. Follow the 3 areas that we are talking about. And there is no reason we can't get it further up the scale, so to speak. But lots of good things we have seen, which I've enjoyed visiting people. And so many colleagues I've met. And as Gerry said at the very beginning, the energy and the desire to improve diabetes care, I think it's fantastic to see across the board.
I think we're a real unique specialty. We're definitely people-centered.
Yeah. So I just want to say a huge thank you also to Becky Thomas for helping us with all the technical stuff today. This is our first proper Facebook Live, and I don't know if Becky's able to come on camera or not. She broke her laptop yesterday, and even still
under a dog as well.
That did not stop her, and she's managed to get us online today and live without any kind of issues. So thank you so much, Becky, for everything. Oh, there she is. Becky, our tech support. And thank you to everyone for listening. Thank you for all of our questions. And I think we're just going to all say goodbye. So Beth, bye.
Bye everyone.
Thank you. Bye-bye. Bye.
Bye.